New England states, and I know that you've heard from some of the governors from the other states, to share our thoughts about this and to put together strategies so that we can collectively also figure out what we learned from that process. So we look forward to working with you and your staff to talk more about this.
Well, let me just interject for a moment. I don't think there's any question that we see Medicare as an essential component of health reform. And discussions are already underway with the new leadership team coming in. Jonathan Blum is there at Medicare. We currently do not yet have a CMS director, but John is very much at the table. And one of the things I've asked our staff folks under John's direction to take a look at is imagine a world where not a single additional piece of legislation passes. What is it within our current administrative jurisdiction that we can do? How far can we move? What kind of flexibility do we have to be really an innovator in terms of not only helping to lower costs, but certainly driving best practices, identifying more cost-efficient systems, ramping up how robust can our demonstration projects be, how fast can we get there. So that discussion is very much underway. We think in both Medicare and Medicaid, two essential building blocks along with the Children's Health Insurance Program of health reform, that those have to actually come to the front of the line and be one of the areas where not only we have demonstration projects, but we try to bring them to scale. And as you say, we've got a lot of market leverage along the way. So it's not only about what's going to be written in the next chapter, but how rapidly we can work with you on these underlying payment shifts and everything from driving a wellness and prevention strategy to looking at bundled care for chronic disease management, post-hospital stay. I mean, there are a whole series of areas that we know we can have a significant impact on quality and cost, and we just are trying to analyze right now how far we can go quickly, because whatever we pass at the federal level is going to take several years to implement, but I think this can be at the very front of the line.
Not here.
Well, I understand. I understand.
Dr. Mata, would you give us a perspective from those who see patients regularly on how health reform has worked?
Thank you, Governor. Yes, absolutely. In fact, I'll answer from the perspective of patients as well as physicians. I think I see everyone here is primarily physicians, and we're all patients. In the bad old days before Chapter 58, everyone would get seen in the ERs, the cardiologists, which is where I practice. I would see the patients, but I would be seeing them at 2 o'clock in the morning having their acute heart attack, then getting them through a angioplasty or a bypass, and then struggling afterwards to get them the appropriate resources after. How can they afford their medications so they don't end up back in the hospital? Many of them would then fall through the cracks, not get the medications, end up back in congestive heart failure, end up back with disease processes. This costs society money, and more importantly, it's bad care for the patient. So now with Chapter 58, things are better. Now I'm seeing the patients as referrals from my primary care colleagues before they have their heart attack, when they're having chest pains or when they're having symptoms, and I'm able to work with them, get them the appropriate care, and hopefully keeping them out of the hospital and keeping them out of needing all these expensive procedures. I completely agree with President Obama when he said health care will save money in the long run if done properly, and that is the right way to go, not just for the physicians in this room, but especially for the patients.
Great point. Thank you very much. There are implications there for public health, obviously, as well, which you've touched on. I don't know whether, Dr. Bigby, you want to build on that, or maybe we could open it up to others.
Desiree also could comment on the public health infrastructure.
I do want to briefly just say something. We focus on the more than 97% coverage that we have, but the real question is, So what's the downstream impact of that? We are lucky to have some early data that show that actually access to care has improved. More people say they have a regular provider. We have seen access for racial and ethnic minority groups improve. The uninsured rate among blacks in the state is about 3.2%. I'm sure there's no other state in the country that can say that. For Hispanics, it's much higher, 7%, but that is still a world of difference than what we see around the country. We know, unfortunately, that people who are in our publicly supported plans have about twice as much difficulty seeing specialists still for care, and Hispanics are still more likely than any group to go to the emergency department for non-emergency conditions. And so we have a lot of work to do still on access. I do want to point out, though, that we just came from the NICU, where we saw an infant who was born at about 23 weeks and weighed about a pound. We know that for every dollar we spend in prenatal care, we save something like $7 in NICU care. Ellen, our goal should be to shut down your NICU or at least get rid of half the beds. And the connection here is that previous to healthcare reform, women often could not get insurance unless they were pregnant, or until they were pregnant, or until they had children that they were raising. We know that infant mortality, which is about 3 times higher for babies born to black women in this state, is related to early access to prenatal care. We know that women who have unintended pregnancies are 5 times more likely to have a low birth weight baby, which is the leading cause of infant mortality. So without a system that covers people consistently and pays for those front-end services, and without the investment in public health, some of the issues that are very challenging to this country in terms of racial and ethnic disparities and lower quality care for some populations will continue to be a challenge. But we're on the right path, and we just need to continue to look at those issues.
Great. Desiree, would you...
Thank you. So I work with Boston Healthcare for the Homeless Program, and I'm a nurse practitioner. And just to touch upon the accessibility to care. So the patients that I work with, they have an economic disparity as opposed to a racial or geographical. And what we like to do is increase the access to care through the different facilities all throughout Boston. And one thing that's made that especially wonderful for our patients is our electronic medical record. It's the same in every single facility. So if they're seen at Boston Medical Center, if they're seen at St. Francis Clinic, as their provider, I can see all of those notes, and I can give them that continuity of care, even if they're not seeing me every single time. And from a public health point of view, one thing that I would like to say is the hierarchy of needs. So I'll have patients that, yes, they have health insurance, but I can't write a prescription for sneakers. I can't write a prescription for a roof over their head. So there are some needs that aren't entirely being met from the pad and the paper. And that's what I like to say.
That's good. Thank you.
Desiree reminded me that Desiree is part of the Health Commission Corps, which is being doubled under funds that were made available from the Recovery Act. And one of the announcements says, so it's very good news, is money will be made available for an additional 3,300 new providers this year, but hopefully every year thereafter, nurses, doctors, mental health clinicians, dentists in particularly underserved areas to fill the provider network. You have 2 experts here in Massachusetts who we've already imported in to be part of this incredible new leadership team in health reform. Dr. David Blumenthal is going to lead the Health IT initiative, and as Desiree just said, having an electronic health record, which is one of the President's goal for every American, is part of, I think, the transformation needed in healthcare, lowering medical errors, hopefully reducing costs, driving